Please.
Yes. So she had actually had a procedure done through the femoral artery on the right side. The angio, I think it was done through the femoral approach, and she has some doesn't that area doesn't look good. So we thought that we'll go through the left femoral today.
Yes. Grind looks healthy.
Ah,
Micropuncture technique.
yeah, we are doing the micropuncture. While doing the micropuncture, always look at the wire when it goes in. Show the groin. Show the groin.
Okay, okay.
Arya, show the groin. Because this wire, it can go migrate into small branches, so it's always good to have make sure that the wire is inside the main vessel. I'll also show you the opposite groin. Can you just focus on to that IVS images? ഇതൊന്ന് മാത്രം കാണിക്കാവോ ഈ image? Enlarge the camera screen. Enlarge the camera screen. Okay, now you can see on the right side, this is the right groin. വെളിയിലോട്ട് വരൂ. Arya, come out. Arya, pull the catheter. Okay. Now when we look at the right groin, see, you can see that there is a flap inside the femoral artery. Can you appreciate that?
Yes, yes.
So that's the reason why we didn't go through that particular right femoral artery. So
Left.
that's why we decided to go through the left. Enough. EBU 3 curve. Now we'll go with the EBU 3 curve and take a couple of images and see how it looks like. Be ready with a... Do we have a Versaturn wire? Okay. That appears to be a significantly calcified ostium. Probably we might need a 3.5 curve. We'll try to see how the images looks like with the 3 curve catheter. Arya, be ready with a 3.5 guide also. Okay, air inside the... Okay, this looks reasonable. Probably we have good pressures. We'll do some images, caudal. Okay, can you little more turn the... Come a little more apicaudal. We'll remove that. Okay. Today it seems as if the circumflex doesn't have... It seems to be diseased but not very critical. Now come to plain AP view. We'll see the ostium of the left main. Okay, rotate it a little bit towards the right. RAO. Okay. Now come cranial. Here the left main appears to be significant. So anyway, we'll go ahead with the procedure. Appears to be significant. Okay. Now get the wire. And we'll do a OCT imaging. We'll try to acquire an image because the flow is there into the circumflex artery. Might be difficult because you have to keep the guide catheter away from the ostium, but still we'll try to get an OCT image. Keep the image epicranial itself. Keep the eye in the epicranial view only, because it's better seeing this particular ostium in this view rather than the caudal view. Freeze and transfer. Okay. Okay, now come caudal. New York guide catheter, New York OCT catheter. Okay, okay. Epicaudal. Can you freeze and transfer the epicaudal images? Okay. Okay, OCT catheter. Okay, purging. That's a New York catheter. Most of the times the New York OCT catheter should travel easily into the vessel. Give me a 20 cc syringe. Okay.
But again, calcium tortuosus may find a little bit resistance.
Yes, with usually the Oxford catheters, but here we hope that it should go in. Especially the new one, it's a more sturdy catheter. The Opstar catheter, this one, the one that we are using, it's a sturdy catheter. Okay, you ready? Yes. Yes. Enable pullback. Okay. Activate. കഴിഞ്ഞെന്നാ അത് ലീഷൊന്നും ഇല്ലായിരുന്നോ ചെയ്ത ഇറക്കാൻ പറയാം Okay, now get the orbital device ready. With microcatheter we'll change it to wiper wire. Meanwhile, I'll get me a 7.5 glove also. We'll go from the distal LCX back into the left main. Can you see the OCT images there? Is it enlarged? Okay, it's enlarged. So probably this area on angiography also, this looks like a reasonably good landing zone. Probably we'll go till here. Distally, this particular area looks good. The lumen looks good, 8.3 millimeter square. Then as we come more proximally, this is the area where we saw the tight lesion in the circumflex. So it's almost 1.8 millimeters. So certainly it's a significant lesion in the circumflex. We do not see huge amount of calcification over there. We do not see good amount of calcification there. That looks more of a fibrotic lesion with some amount of deep calcification. I hope you can see that at 11 o'clock position there is some deep calcium. As we come more proximally in the circumflex, the lumen appears to be good. It's almost 5 millimeter. And then okay, then as we come more towards the proximal circumflex, I hope you can see the co-registered view. So this is the circumflex artery. Here you are seeing a calcific nodule which is protruding into the lumen, and it's away from the imaging catheter. Let's hope that because it's a big vessel, probably we'll go with 120,000 RPM and hope that we'll do something with the crown. We can shave off bit of this particular nodule, and then now as we're coming near the left main, you can see the LED over here. That's the left main. Now we have reached the left main. Here again you are seeing significant calcification. This is all nodular calcification, and that's the ostium of the left main. Ostium also you are seeing nodular calcification. It is actually less than 360. It's a significant nodule, but less than 360 degree arc. So we'll go with orbital. Sir, your suggestions, Dr. Kapadi, your suggestions. We'll go with glide assist mode inside the circumflex artery and then do retrograde sanding. Will that be your option, or?
That is better actually. That is better. Or you can go halfway till that proximal to the bend.
Yeah.
Then glide assist you can cross and then retro you can.
So you mean we'll start antigrade at 80,000 RPM, cross the lesion, and then probably
Glide assist you can go and then retro 80 you can do that.
Okay, okay. Okay, we'll try doing that. So we try with 80,000 RPM antigrade, and then certainly at high speeds we'll do retrograde also. The only thing they say is when you have such an osteal disease, calcific disease, when you try to do antigrade, there is a small chance that you could dissect the ostium, which can extend into the aorta. That's the only thing they say. Now, Vishnu, we have got the wiper wire across. Wiper wire is in position. Now we are getting ready with the orbital. Vishnu, we'll go in. Orbital, we'll go near the Y connector and check all the parameters. Okay, now shall we check all the parameters? Now the wiper fluid is flowing well. I hope you can see that. They are not able to see that. Okay, see, wiper fluid is flowing well. Now we'll, can you enlarge the camera image? Now we'll see the speed check. That is, we'll go at 80,000 RPM, and brake is applied, and then we try seeing the speed. Okay, it's working well. It's working well. Now we go on to the advancer knob. It's moving freely forward and backward. Now we'll fix it there. We'll fix it there, and now the brake is also working. So we'll release the brake and then go inside the coronary. That's what we'll do. Now enlarge the fluoroscopic image. You can have picture-in-picture of the table. Yeah. Sir, is it not safer to go, again thoughts, is it not safer to go retrograde rather than trying with antigrade?
You can go.
Chances of aortic osteal dissection, the left main osteal dissection can be reduced.
Yes, yes, definitely. You can cross with the glide and then...
Yes, we'll cross with glide. Okay. We'll go with glide assist mode. We are going with the glide assist mode. Can you focus on to this particular area? Okay. This light is blinking on and off, which means that it's a glide assist mode. Now we open up the knob, and then Anisha, hold on to the wire. Hold on to the wire, and with glide assist mode, we'll push it into the. Okay, we've gone into the vessel. Okay, we'll stop. Now press once again so that it goes on to the 80,000 speed, and then apply the brake. Now we'll start sanding. The pressures are okay. Now, next time when we do the atherectomy, just push the wire distally. After releasing the brake, once something like rota, if the wire comes back, what we could do is release the brake, and then during the bearing, you can push the wire distally. 27 seconds, 30 seconds. Okay. Now the next. Yes. Okay. Okay. So that cannot be done with orbital. When you release the brake, it goes off.
Yes.
The button goes off. We have never tried that previously. There should be some technique of pushing the wire across. I think probably we can just release the brake and push it with our push the wire. Yeah, it's going. It's going in.
Yes. Yes.
It's inside a branch, so it's not moving further distally. I think that we'll apply the brake. Okay. We didn't touch the distal lesion because in the distal lesion there appears as if there is no significant calcium at all, no intimal calcium. It is more of deep calcium, and again it's not a significant arc, less than 180 degrees, so probably we wouldn't do anything for that.
Yes.
Now shall we go at higher speeds?
I prefer higher speed, only retro.
Yes, only retro, yeah.
But that speck of calcium is there proximal to the bend.
Yes.
You can go at retro 120.
Yes, we'll go little bit forward, and then come retrograde so that we can touch the both the lesions also, the one inside the circumflex and the ostium.
True.
That's what we'll do.
True.
Okay, from there we'll come back. Pressures are good. No hemodynamic abnormal. Probably it's a circumflex artery. That's why hemodynamics are all good. What is your routine practice? Do you use 6 French or routinely it's 7 French, and in case you're stuck with a 6 French, you do with the 6 French orbital?
In general, routine 6 French.
6 French, okay. ഒരിക്കൽ കൂടെ കുറച്ച് ഡിസ്ലി പോയിട്ട് we can come back. Then probably we'll do once again, and then see this time we'll see how the pitch change happens, and if there is significant pitch change, probably we'll do it. We'll do it once again. Otherwise, following this, we'll do an imaging. And after imaging, probably we'll go with a 3.5 balloon. Do we have a 3.5 Wolverine? We'll hold on. We'll do it once again. The ostium alone, we'll do it once again retrogradely. And 10 seconds. Ox, yeah. If Wolverine doesn't go, then we'll go with a 3.5. Meanwhile, can you see the vessel size distally, proximally, and all?
OCT, what is the size distal?
Yeah, we'll just check it. It's not calcified. There is some calcium, but it's not. It appears to be a soft lesion there. Minimal luminal area is below 2. We'll cover that particular area also with the stent, but I think orbital is not needed. Okay, check. Hard and slow. There.
Portion.
Stop. From there, distally ponda. We won't go distally. From there, we'll do a last retrograde sanding and stop. One more retrograde, slow retrograde, and then we'll stop. We'll wait for another 15-20 seconds. No, that's not the distal landing zone. Go more distally. Distal, looking at the yellow box. Distal, further distal, okay, there. Check the vessel size. It's almost 3.5. So certainly we'll go with a 3.5 stent. Okay, slow ആയിട്ട് retrograde മാത്രം വന്നാൽ മതി. Ostium വരെ. Now the Versaturn wire and then the OCT catheter. Okay, enough. Now shall we take it out?
Yeah, please.
Okay. So glide assist. Brake release. Glide assist. Okay, push the wire. Now again the microcatheter and then the Versatone wire. Okay. Okay. Microcatheter and the Versatone wire. And then we'll do the imaging. Once we are done with the imaging, we'll try to dilate with a Wolverine. If it doesn't go through, then a non-compliant balloon.
I think usually Wolverine balloon may go, but sometimes these type of beds and all these things little bit friction.
It will be difficult, yeah.
You may get with difficulty. And you can take routine NC or OPN balloons also.
Yeah.
Compared to the descending order.
Yeah, negotiating a
OPN NC.
True, negotiating an OPN would be better than negotiating a Wolverine. Now the Versatone wire. And the indiflator. Twelve, 14, 16. Okay, okay, it's come out. Okay, so now the OCT catheter. A small perch. OCT image, is it okay? Joel, what is the length over there? Ostium to the on OCT. Okay, we are ready with the imaging catheter. Live view. Yes. 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 Activate. Anisha will take this out. Now the balloon. Ah. Can you get me a 7.5? This thing. Huh? 33. So as we come back from the circumflex, this is the area where we had that tight lesion with no much of calcification, but here you can see that this particular area, whatever calcium was there, the imaging catheter is actually gone into the vessel, and that is okay. Now I will show you that once again. That's the amount, that's the calcium there. The entire calcific area has been shaved off by this, because the imaging catheter is so close to that particular area, it's almost going into the media. And then as we come more proximally, We are coming till the ostium. Here again you can see at 6 o'clock position that particular small nodule has been shaved off from there. So that's the nodule. You can see that there is a significant amount of volume reduction. I hope you can see that from 9 o'clock till 3 o'clock position, this much of nodule has been shaved.
That is very classical,
shaved.
Dr. Deepak Davidson.
Yeah, yeah.
Classical gutter-like
Yeah.
shaves.
Yes. Now we'll go with balloon. Okay, Vishnu, balloon. What about balloon? It's tracking in. Huh? Ah, it's gone in. Okay, we'll dilate that. That lesion also. This is 3.5 Wolverine, right? Okay, we'll go up. Huh? Wire, we'll pull back the wire little bit. Okay.
Still is.
28 over, eh?
Easy to N balloon.
No, Wolverine is an ox.
Ox
Yes, yes. Vishnu is capable of pushing it in.
Made of ox balloons.
Is that a air bubble or?
It seems a little bit underexpanded. Proximally, dog bone effect is there.
Was that an air bubble? It's an air bubble. It's not a dog bone. It's opened up well. Negative.
But previously, the proximal to the calcific lesion, some little bit dog boning is effective.
Vishnu, did we make out a dog boning or is it the? Illa sir, Dr. Kapadi. We'll dilate it once again there. Little more distally. Oh yeah, there. We'll go up at 12. Always slow negative.
Disparity. You saw the disparity of the balloon.
Yes, pull back another 3 millimeters and we'll go at little bit higher pressures. Always, while we use a Wolverine, the inflation as well as deflation should be slow. Deflation also should be slow so that you have enough of time for the balloon to rewrap. Now it's opened up reasonably well.
Yes.
Now we'll inflate at the ostium also.
It is for preparation, so it is acceptable. Post-stent, it is not acceptable.
Yes, yes. Now, this is what length is it? 3.5 into 10. So 28 would be enough, right? 14.
So what is your experience with the ox Wolverines?
We do not.
No, just I am asking.
We haven't had any ostium.
Any ruptures? How?
Yeah, it is stuck. It has never ruptured. We'll dilate it once again.
How frequent you observe?
We always try to dilate it at high pressures outside the guide catheter before we go inside with the Oxford ones. Negative. It's opened up well. Once again OCT run.
Right. So in vitro you give 5 tests to the Oxford balloon.
Yes, that's what we do. We dilate it up to 18 atmospheres and then take it inside the coronary. And there we don't go up to 18 inside the coronary.
Right.
OCT catheter.
So very good with tips and tricks. We have no experience
with Ox.
We have no experience with Oxford cutting balloons especially. For angiosculpt we have bulk experience, but for the cutting balloon we are not there enough like you.
We'll OCT catheter. Now 3.5. 3.5 into 28 would be fair enough, right? Be ready with a 3.5, 28. Yes.
Here actually the OPN sometimes serve the purpose safety. And as I told you, we had bulk experience in positioning the Wolverine into that type of tortuosity. Usually some little difficult Oxford balloons to take, especially cutting balloons. Because of the metallic bun, it behaves like a stent, difficult to negotiate.
Okay, ready?
I think, yeah, OCT, yes.
Okay, we are ready. Yes. Okay. Yes. Activate. Now once again we'll assess the length and then
Yes,
open the stent.
but very good preparation actually. Lesion preparation is very nice.
Yeah, we'll get a 28 stent. Joel, freeze those images and show the cracks and all, if at all we have seen anything in the ostium. Those are the dissections that we have seen. As you come more, no, show the ostium of the left main. Okay, Anisha, give the stent. 3.5, 28. Then 3.5 and 4.5 post dilatation. Yes. Anyway, the luminal gain is quite good at the ostium of the. Come few more frames backward, near the guide catheter, proximally, more proximally. Yeah, that is what we have seen at the ostium. That appears to be reasonable length. Come cranial.
Hello, cranial.
Oh, we need to come few more millimeter backwards. Yeah, we might miss the distal lesion.
Yes, correct. Maybe you have to take 33.
Here appears to be reasonable distally also. Come caudal. We'll check it in caudal view and once again go cranial before we deploy epicaudal. Yeah, it seems reasonable.
Yes.
Again come back to cranial view.
Yes. Proximity you have to see.
Yeah, here it looks reasonable.
Covering.
Yeah, we'll go.
Covering the ostium.
10, 12, 14, 16. Negative. Now once again 14, 16, 18. Give a 4.5 balloon. Negative. Come caudal. Okay, we have covered the distal lesion also. .5 and 3.5. 4.5. 4.5 into length. Okay, show the previous image. We'll just have to dilate the ostium alone with the 4.5 balloon, and rest of the stent we'll dilate with 3.5. 14, 16, 18. Negative.
Why you are doing in vitro testing?
It's all Oxford balloons. These 4.5 once you're inside the coronary, at times it doesn't open up because of the contrast inside the balloon. So we always try it.
Whether can
Make
withstand
sure,
or not.
make sure that there is no pinhole ruptures before we push it in.
Okay, okay. So what is the lifespan ultimately? 6 times or 10 times?
Not sure. We don't check it that way. As long as it works, we use. Keep reusing.
That's all. Okay. But deliverability is a little bit difficult, no? As the
Yeah,
balloon
because
says
it's
more and more.
yeah, because it's left main ostium. That's not a come cranial, come cranial.
As the balloon size larger and larger, it becomes bulky like
Yeah,
a
it's
flower vase.
it becomes more and more difficult. Yeah.
Difficult to deliver, no? Yes, yes. We delivered 2 cars, 1 person.
Okay, we'll go up. 14, 14, 16 seems to have opened up very well. 18, 18 and negative. Negative. It's all right. It's all right. Now it is 3.5 balloons. Yes. 3.5 and then OCT catheter. Yes. Huh? Caudal. We'll come caudal. And then once we are done with the OCT, probably finally before we stop, we'll take the 4.5 balloon once again and dilate the ostium once again at little more higher pressures. Angiographically, it doesn't look as if it's fully expanded. 14, 16, 18. Negative.
You are not satisfied with the balloon dilatation?
Balloon opened up well.
But
Angiographically, this image
still needs some dilatation.
dilatation. Caudal, come. Okay, we've. Fourteen, 16, 18. 16. Negative. Negative. 18. 18. Negative. 18, 20. Negative. 20. 20. Negative.
It's actually very good stent expansion.
OCT catheter.
Yes. For fibrotic lesions, you prefer Wolverine balloon?
Wolverine, yes. More of heavily calcified Wolverine doesn't track into the lesion, whatever, unless it's a very focal. When you have extensive calcification, many times Wolverine doesn't track into the lesion. But always following rotor, do NC balloon dilatation, and still if the luminal gain is not good, you can always go after NC balloon dilatation. Once again, final touch with a Wolverine probably would fetch you better luminal gain.
Okay.
That's what Dr. Samim Sharma's rota cut study has showed.
Correct.
Show the image, live view, enlarge the OCT images. Contrast. Auto calibrate. Yes. Okay, we are ready. Yes, enable pullback. Activate 4.5 balloon. Shows the most distal area, which is we have actually landed on a small nodule, but then there is no dissection over there, no significant dissection over there beyond the stented segment. It's a small nodule there. Now frame by frame backwards, come frame by frame backwards. That's the stented segment. Now come proximally 4.5 balloon.
It's basically a bend area, distal.
Yes, yes. That's come proximally, more proximally. More proximally, the luminal area is 10, 9, 10, 10.
Yes.
Till the ostium, show till the ostium.
Yes, it is
Those are the areas where we saw, okay, saw the calcified nodule. Go distally, one frame distal. Okay, that area looks 11.5. That looks good. I think we'll do a final dilatation with the 4.5 balloon once again right at the ostium and stop.
Yes, but don't chase the wall. You chase the lumen.
Yes. Come show the balloon, or show the remove the overlap, move towards more towards the right. Let's say okay, okay, that's good. Yes, we'll go 12, 14, 16, negative. Once again 12, 14, valency negative. Okay, 12, 14, 16, negative. Nitro and final shoot. This view, epicaudal and epicranial.
In your experience, when you are using Oxford NC balloons, how frequent, how safe not causing stent deformation?
We are very careful. We when you have a stent protruding into the left main from the into the aorta from the left main, we are very careful while pushing in the balloon. And if we feel that the stent is too much into the aorta, then always it's New York balloons.
Okay, right.
That looks good. In this view, you can see that at the end of the stent, there is a small nodule there.
Yes.
Nodule there. Okay. Caudal and cranial. Really alpa left. Left. Okay.
Yes.
Cranial.
Just like a small topi like thing, actually.
Epicranial. Little bit RO. Okay.
Yes.
There appears to be a small dissection.
Non-occlusive
yeah.
flap, which will heal.
Yes.
It's a non-occlusive flap which will heal. Just like a topi. Hat-like.
Show the bladder. Bladder. Okay.
result for the touch was with the safety orbital.
Yes, yes, even
Retro 120. Retro 80.
even I didn't expect that we'll get a reasonably good result like this. Switcher.